I'm delighted to welcome our first guest today, which is Dame Sally Davids. At the risk of embarrassing you, Dame Sally, I'm going to tell them a little bit about you. Okay, so Dame Sally was appointed as the UK government Special Envoy on AMR in 2019. She's also the 40th Master of Trinity College at the University of Cambridge, which makes her a neighbour of one of our guests. Do you want to give a wave? Who lives in Cambridge at the moment? That's Juliet. There we go. So Juliet's at another college. So Dame Sally was the Chief Medical Officer for England and Senior Medical Advisor to the UK government from 2011 to 2019. She is a leading figure in global health, having served as a member of the WHO Executive Board from 2014 to 2016. And we have someone from WHO here as well. And as co-convener of the United Nations Interagency Coordination Group on Antimicrobial Resistance, reporting in 2019. In November 2020, Dame Sally was announced as a member of the new UN Global Leaders Group on AMR, serving alongside heads of states, ministers, and prominent figures from around the world to advocate for action on AMR. In the 2020 new honours list, Dame Sally became the second woman and the first outside the royal family to be appointed Dame Grand Cross of the Order of the Bath as a GCB for services to public health and research, having received her DBE in 2009. So with that introduction, I'm delighted to hand over to you, Dame Sally.
Thank you so much. And I see that I'm in reverse, at least on my screen, compared with everyone else. So does it make sense? And I'm really excited about today's meeting. It's not just about antibiotics and resistance. It's about gender and sex and equity. And we all know how important this is. Antimicrobial resistance, AMR, is a global problem. It needs global solutions. Functioning antibiotics and products are a critical bit of modern infrastructure. Imagine health systems without them. And I'm sure Murphin will talk about health systems where they haven't got access and the impact on women when that happens. The loss of antibiotics put the foundations of modern medicine really at risk, whether it's cancer treatments or just transplants, whatever, it's all at risk, even cesarean sections, which matters to today's discussion. We've also got to remember that within the global health threat of AMR, not only is there gender equity, but there's not enough understanding of how gender impacts AMR. And I think this recent paper from you at Itad helped steer us in the right direction to stimulate our conversations and encourage yet more information and study on how gender impacts AMR. After all, AMR is not simple, nor is it just a one-off challenge, or we might have solved it, all of us, before. It's a long-term threat that will go on forever. Much as the pathogens it relates to, it's constantly changing and evolving. And we know that the first step to solving a problem is to fully understand it. For AMR, this means having access to as much high-quality, real-time surveillance data as possible. And that actually does include data on gender. The Fleming Fund supports countries to produce quality surveillance data. And as a community, we've got to continue to leverage this work to build resilience and best practice for low and middle income countries to take forward, let alone ourselves in the richer countries. Thanks to the paper we're going to hear about and discuss today, we're making important strides towards understanding gender and AMR better. We all know we're not quite there, but the fact you're all here means we're moving together one step at a time. Whilst we are developing better methods of tracking and analysing AMR data across human health, animal health, and the environment, we need to ensure appropriate resources are invested in further research about the impact of gender and AMR in all sectors. And with this understanding, then we can go on to design the interventions that are targeted and effective for those needs of the ones most impacted. I know in this Zoom room today, we've got really the right mix of organisations to help drive this forward. And I do believe together we possess that collective power needed to drive forward the agenda of understanding, addressing, and ultimately the important bit of mitigating the impact of the intersections of gender, sex, and equity on AMR. Our commitment today is not just a testament to progress, but I believe it's a promise to forge ahead towards a healthier, more resilient future for all. Through this discussion, I'm looking forward to hearing from panelists and those in the audience on how the Fleming Fund and AMR community can act on the findings of your study and what can be done to accelerate awareness nationally in various nations, as well as in the research community. Lastly, I'm really looking forward to hearing from the panelists their practical experiences and lessons learned so far. I hope all of you enjoy the discussion and join in, and that it helps accelerate our shared vision of a world free of drug-resistant infections. Thank you.
Thank you very much. And guests, I hope you were listening. So this is what we're going to be listening out for, is your practical lessons learned. And the question I kept asking you was, but what can I do with all of this, all this energy and this awareness that I now have? Okay, so let's crack on. Thank you so much, Dame Sally. And if you have to leave us, thank you for joining us for the opening session. So I'm going to have a chat now with Jada Tutan, who I'm really happy is a colleague of mine. So I've been working with Jada on the Fleming Fund evaluation team since the beginning of phase 1. Well, I don't really know what to say about Jada, except she does this wonderful combination of being plain speaking, intelligent, well-informed, and passionate about everything, but particularly gender equity. So Jada, if you want to unmute, perhaps you, as the author of one of the authors of the paper, could you perhaps tell us a little bit about what we need to know about you to kind of make sense of where you're coming from?
Yes, thanks, Cheryl, and thanks, everyone. So nice to see you all here today. I'm so excited. And yes, Cheryl said, I'm particularly passionate about gender inequity. And but yeah, like for a living, like I'm an independent consultant now, like an evaluator, working in global health, in global health. So previously I was working at Itad for a long time, where I started as a member of the evaluation of the Fleming Fund back in 2016. And since then, I've conducted a lot of evaluations. Well, this one, the main one on AMR, but I also work with Gavi on vaccines or Global Fund. Yeah, and always I try to apply in everything I do, in all the work I do, a gender inequity lens, and trying to mainstream that into my evaluation work.
Great, thank you. Okay, so I really kind of want to know why you felt this study needed to be done. So you're one of the authors. I better give its full name, although I'm sure everybody's read it by now. So the paper is Using Intersectionality to Study Gender and Antimicrobial Resistance in Low and Middle Income Countries. And we'll be putting a link to that in the email that goes around to people afterwards. So, you know, why did you want to do this study, and why did it need to be done, do you think?
Thanks, Cheryl. Yeah, as I briefly mentioned, I started working on the Fleming Fund evaluation back in 2016. And at that time as well is when I became more interested in gender mainstreaming approaches. And I started asking myself and others, so how can we apply those approaches to the Fleming Fund and in general, you know, to the fight against AMR? And at the beginning, yeah, like I must say, like it was a bit tough. Like people were like asking, but why are you asking these questions? And seeing the problem, as we've heard many times, as a problem about drugs and bugs and about laboratory equipment and laboratory strengthening, which of course is very important in itself. But like people were struggling a little bit to see the link between these drugs and bugs combinations and resistance, etc., and the human face of it, and the link with the people, and why then things like gender and sex and gender norms mattered. Then like fast forward like 3 or 4 years, I think back in 2021, the environment was much more enabling, and the HSC also, like, and Fleming Fund decided to uphold the principle of gender inequity as an additional new principle for phase 2 of Fleming Fund. So I was involved in those conversations, and we identified an evidence gap. So, like, in order to be able to act on it and do something meaningful for gender inequity in AMR, we needed more evidence. Fleming Fund commissioned to Itad this study, like firstly a literature review that then was turned into this paper that has been published in August. So yeah, that's why I really wanted to be on this project, and I'm very thrilled. And of course, the paper built on work done by some of my colleagues here. Like the first very paper on the subject was, I think, a WHO paper tackling AMR together in 2018, followed by a scoping review by REACT colleagues in 2020. So yeah, what Juliette and I and other authors have done is just building on those great starting points.
Great, thanks, Shada. Perhaps you could just explain why you refer to them as your colleagues. We should probably mention about the group that you have going on and what happened last week. Could you say something on that?
Yeah, thanks, and I'm sure Sarah will be telling more. But like many of the colleagues here in the panel today are also member of an informal expert working group the WHO has convened, to provide advice for a policy paper that has been funded by Fleming Fund. The work has been funded by the Fleming Fund to come up with a policy paper on how to take into account and integrate a gender lens into the national action plans for AMR, basically like practical guidance for countries when they renew their NAPs. We have met a couple of days in Geneva last week to discuss and co-create recommendations.
Great, thanks. So when we had a chat before about the paper, I haven't read it, I promise, but I was asking you whether women come off worse generally in terms of AMR, or is it just about that it's more important to recognise the difference?
Thanks. I mean, in terms of burden, unfortunately, we don't have exact data yet. I know the GRAM project, also funded by the Fleming Fund, will produce the first estimates of burden disaggregated by sex and age by Q1 next year. So we will have more of an answer then, perhaps. But like in terms of what we've found in our work, it's definitely mixed. And when I talk about gender, I always emphasize, and I'm sure like all my colleagues here, that it's not just about women. Of course, like as the paper shows, women suffer from gender norms and some lack of resources and lack of education in certain settings that cause them disadvantage, for example, in terms of how aware they can be of the dangers of AMR, or how able they can be to seek like the advice of a doctor for a prescription, for proper use of medicines for self and for others. But like in the paper also, we try to do justice and cover all dimensions, at least all key dimensions for men as well. Like for example, linked to occupations, we see that certain occupations like animal slaughter, for example, or rearing of certain animals that are mainly men-dominated at least in some cultures, come with a higher level of exposure to drug-resistant organisms. Also some behavioral aspects, some notions of masculinities that can make men have more risk-taking behaviors vis-a-vis sex or smoking or other things that can lead to higher likelihood of get tuberculosis or sexual transmitted diseases, etc., etc. So it's really mixed, like it's about all genders, and we try to make it non-binary as well. But like the evidence on non-binary genders and AMR was very, very thin. So this is a gap that can be filled perhaps hopefully in the future with some primary research. But we also like focus on, for example, stigma around certain sexual identities or behaviors, like men who have sex with men, that tend to be less likely to seek in certain settings medical help and diagnosis out of fear, for example, in countries where these behaviors are not legalized.
Okay, great. Thank you. I think at this point, I'm going to turn to Juliet and bring her into the conversation. So Juliet is one of your co-authors. So she's also a consultant on the Fleming Fund evaluation. She led the research and the writing of the paper. So she's going to talk to us a little bit, aren't you, Juliet, about what the paper actually found out. And I had some specific questions for you, really. So the questions that the paper had were, I'm just going to read them so I don't get them wrong. How do sex and gender, compounded by other social stratifiers, influence vulnerability and exposure to AMR? And the other one was, how does gender influence health-seeking behaviours related to AMR, such as antimicrobial access, use and administration to others? So I promised you I was going to ask you, kind of what did you expect to discover? What did you go in thinking that you were going to discover about those, and then what actually came out, and were there any surprises for you?
I think we came in with kind of a very open mind to find out what there is, because there wasn't much that was out already. The interesting thing here was kind of that there was nothing really comprehensive that brings a big overview of the literature and the research on AMR. So as Jada mentioned, we started with this REACT and WHO paper. But from there, we were kind of on our own, and this research really came out of this gap. And then we had to piece this information together. And I think the main surprise that I had was how little there was specifically on AMR. So our study is kind of a start, but should definitely be supplemented by first-hand research that should hopefully come out in the next few years.
Okay, cool, thanks. And would you say what's the most interesting thing that came out for you? Because we were talking about how applicable all of this is and what do you do with it. So what came out of it for you?
In terms of the findings, I think what I found was quite interesting is how interrelated. Well, we were really looking at this intersectional lens and the interrelation between WASH, gender, sex, and kind of other social stratifiers through different kind of main themes. And so I can run through a couple of examples if that's useful for great. Kind of maybe looking a little bit more at, I would say, WASH, maybe sexual behaviors and health-seeking behaviors, some of which Jada has already kind of mentioned. But if we look at WASH, for example, and UTIs in particular, they highlight quite well the intersection of sex and gender and other social stratifiers without them being kind of separate from each other. And they're all kind of compounded and heighten one's vulnerability and exposure to AMR. For example, the risk of developing a UTI, which have kind of high drug resistance potential, is increased in low resource settings where WASH facilities aren't quite readily available. And this can be compounded as well by, for example, practices of menstrual seclusion, which also heighten the risk of UTI through a lack of menstrual hygiene management. And in addition to this can also be compounded by a biological factor. And so looking at sex, where females are biologically at higher risk than males of contracting a UTI due to the physical characteristics of their sex, such as having a shorter urethra. So the bacteria are more likely to infect the bladder, for example. And so this, for example, demonstrates kind of how gender really interacts with biological and social economic factors, and geography, for example, and other cultural factors to really exacerbate, in this particular case, women's and girls' vulnerability to potential drug-resistant infections. And I think WASH, if we look at WASH as well, it really highlights the need for a focus on human health, animal health, and environmental health. There's often this one health approach that's quite important in AMR. Lack of access to clean water is often a primary kind of environmental AMR reservoir and dissemination pathway. And globally, I think at least 2 billion people use drinking water source that's contaminated with feces. There's antimicrobials in water that's downstream some antimicrobial manufacturing sites have been found at kind of higher concentrations, at concentrations that are higher than in the blood of patients who are actually taking the medicine. And at the same time, proximity to animal in for example, low and middle income countries, in the case of animal husbandry, and compounded by poor kind of wash facilities, also really raises the risk of acquiring a drug-resistant organism of zoonotic origin.
I've just remembered one of the really interesting things about you that I should have mentioned at the beginning is that you're not an AMR person, are you? You have an anthropology background. And so what I think is interesting about your involvement in this is that you came to it with this, well, I've always been interested in gender, and I'm assuming there will be something it's going to be worth looking at. Do you think that helped you kind of see things differently, maybe from people who work in that drugs and bugs environment?
Yeah, so I come from a very kind of academic and anthropology background. I'm currently doing a PhD in anthropology. And so I really came, I think, with this social kind of anthropology lens, which comes with this intersectional and gender approach, which fits very well. And I think what I found was really great here was it's quite a novel approach, and it can kind of initially be surprising and really requires kind of collaboration between very different fields. It's kind of bringing a very social perspective to a very biological and medical one. And with this, we're really working towards great kind of interdisciplinarity and multidisciplinarity, which, is kind of key to understand, to better understand the world in which we live. And today it's kind of great to see that so many people are starting to be interested in this topic and this bridging between these fields.
Yeah, because we were talking before about how, people are quite in their domains, aren't they? So if you're in your kind of medical domain, it's really helpful to have someone bring in the social perspective. Did you find anything out about AMR that surprised you? Did you kind of, you were the gender person, but how well informed were you on AMR when you came into it? And any surprises for you there?
So I've been working on the Fleming Fund for over 3 years now. So I think I came to AMR quite new and coming with this kind of more academic anthropology perspective. So to be fair, I had everything to learn. So it was a big journey, and kind of bringing this gender perspective was great at the same time.
Great. Okay. So I'm going to come back to Jada in a minute. I just want to ask you, really, what are you hoping is going to happen as a result of this study?
I think, as Jada mentioned, there's more that needs to be done in terms of further research topics. We use an intersectional lens to look at gender, but we mostly focus on gender and sex as binaries, looking at men, women, males, females. So with the scope of this paper, we didn't get a chance to kind of explore fully the place that non-binary or transgender individuals have, and differentiated vulnerability and exposure. And in addition, also further work on including disability with this intersectional lens would be useful, which we didn't get a chance to do. I think in addition, what needs to be done, I think what I was most surprised by was, while working kind of on the Fleming Fund and working on this paper, was that lack of data for AMR in terms of, and what I mean by that, the lack of disaggregated data by sex or age. And to kind of only name the basic disaggregation possibilities. The most recent estimates were not disaggregated by sex or age or any other kind of socioeconomic characteristics. And despite the fact that at the lab level, this data is collected and known when collecting samples, and this data does exist, as we've understood and seen through the Fleming Fund evaluation and kind of the local labs in different countries. But this is not passed all the way through at global level, and some global reporting mechanisms don't have that. And so at some level of reporting, this information disappears. And for me, that's the first place to start. And Jada mentioned that with GRAM, sex and age disaggregated data will come through, which is already kind of a great step. For me, the first place to start is really getting the data. From that, we'll then be able to start to understand other trends and global trends at the global level when it comes to these different social stratifiers. And then another note is we know that sex is probably an accessible metric to collect and use, but other metrics such as gender, especially if we're talking about non-binary and transgender people or other sexual orientations, that might start to be difficult to collect because of discrimination and kind of unsafe for a patient to disclose this. And and other data like cultural practices might not also be possible to represent on this epidemiological level. But that's where I would say that anthropological approaches come in really useful and really handy to kind of into this picture, to allow this more broader contextual approach of AMR at the community level.
Great, thanks, Juliet. I'll probably come back to you later when we've heard from a couple of other people. I'm going to go back to Jada now. Jada, is there anything you want to build on what Juliet was saying about, what you hope's going to come out of this, and what people can do about it?
Thanks. And I'm sure my other colleagues in the panel will add to this, because we have just been discussing this in Geneva at the end of last week. But beyond data and the need for filling certain gaps and the need to have better quality sex disaggregated AMR and AMU also usage data. Ultimately, what I hope will happen is that this paper has showed, this another paper that are coming out at around this time will have shown that it matters, so that sex and gender dimensions do matter for AMR and tackling AMR. And with that in mind, that this perspective is taken into account when planning a response. So there are different ways of responding, to AMR. One of it is collecting better data, but data for what, to be used how. So then in terms of the responses, we have things like better wash, so better water and sanitation and hygiene. Of course, this in some settings needs to be improved for everyone, but building on the findings we had in the paper, for example, we've shown how poor menstrual hygiene is linked to a higher risk of AMR. So this would be measures to ensure that menstruating individuals have access to proper products to deal with that, and that will also have a lot of other benefits, will have education benefits and other benefits. And then if we think about IPC, so infection prevention and control, it also came up quite strongly during the COVID crisis. There has been these calls for better fitting PPE, personal protective equipment, because many masks and other garments for PPE are often designed with one size fits all, and this size tends to be fitting bigger bodies rather than smaller shapes. So there is something to be done, for example, about that. And I mean, I cannot go on forever, but for example, in terms also of power, decision-making power, within hospitals, but also within households. And I don't know, things like behavioral change or social norms, campaigns or programs in order to try to rebalance decision-making power within the households, because often it's for women, to, for example, make certain decisions regarding the health of their children, but at the same time, they lack agency or financial resources to then be able to go take the bus and go to the doctor. And lastly, also take this opportunity maybe to answer one of the questions by Ife in the chat. Programs related to nutrition, we haven't spoken enough so far. A part of our paper looks also at the likelihood of becoming ill once you get in touch with a drug-resistant organism. And these factors that increase that likelihood are things like poor nutrition, also being pregnant or not being vaccinated. So these are things that could be improved, especially for more disadvantaged groups that and we have some data on how women, especially young women, also worse, young pregnant women tend to have poorer level of nutrition than other groups. So this is something also that could be taken into account. Thanks.
Great, thank you. Well, do you know what I'm finding fascinating is that you're all talking about things that I keep hearing the other person talking about. So Murphin, quite a few of the things that Jada was just saying came up in our chat last week. But I'm sure you've still got plenty more to say, even though she's taken some of your juicy bits. So I'm going to introduce Murphin now. So we've got Murphin Mpundu, who is the director of REACT Africa. He's a member of REACT's global leadership team. He provides countries with technical assistance on national action plan development and implementation. And he works closely with the tripartite organisations, including WHO. He sits on several boards, including the Wellcome-funded Surveillance and Epidemiology of Drug-Resistant Infections Consortium and the External Advisory Board of the Newton AMR Drug Discovery Programme. In 2020, he co-authored the report titled Scoping the Significance of Gender for Antibiotic Resistance. And as we've already heard, he's a member of the WHO Informal Expert Working Group on Gender in AMR. Hello, Murfin. How are you doing today?
I'm doing great, thank you.
And where are you based? Where last time I spoke to you, you were moving around all over the place. Did you make it to the UK?
No, back. Yeah, no,
You're
I'm
back.
Actually, yeah, yes, yeah. Thank you so much. Yeah. So it's really wonderful to and important for us to look at this really topic from different perspectives, and I think the setting up of the scene by Dan Sally was actually very great. And also, I mean, Juliet and Mujada, who did this particular study. It is a study, it is a study that, not this one in particular, what actually drove me to start looking at gender and also AMR, what interactions really are there? Primarily, it was when we started looking and making the argument around SDGs, and clearly when we started saying that there are a number of SDGs that directly impacted by the existential threat of AMR, and some that are not directly really impacted, but they would be impacted because of the severe really consequences on actually other sustainable development goals. The other reason was, I started thinking a lot about, what are the major differences indeed when we look at the global north in terms of determinants of actually antimicrobial resistance. And it started getting clearer that, the major determinants in the global south largely are the social determinants of infectious diseases. And it was important to actually do that. So when we look at inequalities, we're looking at strategic goal number 10, and where we focus on really reducing inequalities within and among countries. Goal number 5, achieving gender equality and empower all women and girls. We started seeing that, there's something that probably we have not looked much into, that, AMR increases, as we will all agree, it increases inequalities with actually societies. And so, if it really increases inequalities, what are the major vulnerable groups that we see? And clearly, women came on top. We looked at the children, the migrants, the refugees as some of the groups that actually are impacted. But we wanted to take a broader lens in looking at gender really as a social construct, and not just as a binary issue of male and female. You look at really the spread of the differences among male and female. You look at issues around the workforce. Really, 70% of women around the world work in health institutions. And so they are going to interact with these resistant pathogens within the confines of their work. We look at whether it's in agriculture, the ratios remain the same. we look at issues around non-communicable diseases. Again, we see those socials, those issues of disparity. And so, we look at the women's health and actually the seeking behaviors. Again, we see that there's a different. Women are more likely to receive an antibiotic prescription compared to men by 27%. Lack of knowledge, networks, economic resources, literacy levels have a greater effect on women. Gender norms and preferences really affect actually access to healthcare. And so when we look further in terms of work and exposure, whether it's in agriculture, like I said, it's in the human health sector, again, we see that. So in the low and middle income countries where I spend most of my time is that, we've got really stringent social cultural norms. We've got low levels of education for women. We've got limited health information and networks, and lack of actually adequate water and sanitations that my colleagues have talked about. So I'll build on this actually later on in the conversation. And so, it became very clear that, we need to start considering these sort of differences and the challenges that, when we are looking at, guidelines, we're looking at the knowledge that the clinical staff have to have. It's very, very important that we take these issues actually quite seriously. And then this year, we had our REACT annual conference in August, and there is one of the most respected clinicians in the region. And, after I made the presentation around, gender and inequalities, she came and said, what, I really have practiced over 30 years. This is an area that I never thought about. This is the first time that I'm getting to see, oh my goodness. So there is a complete difference, and we need to address such differences when we look at that. And I think, and it goes to really even being able to collect the data at the hospital level, at the national level. We see the prescribing patterns. We look at, there's, with this I end, we look at a condition that has just been mentioned, UTIs. Clearly, we see the sort of stigma that comes with that. And if you are in a low and middle income country, you realize that the first point of contact, unfortunately now, is a drugstore. And so, what are they going to come and say if they find that the provider is a male? What are they going to tell their spouses or husbands? Because, they will not differentiate a UTI and an STI. So, they will just think, oh, my wife has been misbehaving, or my girlfriend has been misbehaving. And unfortunately, some of them are going to, get beat up. And, and those sort of, we see again, that, this is really, really important for us to be able to address. And I think with that, I'll give back to others to also actually weigh in and not take too much time. Thank you.
No, you never say too much, Murph, and it's cracking stuff. Actually, we've got a few people on the line here who work or familiar with the WASH sector, and it is interesting for me how these things. I used to work on a WASH program. I work on a sexual reproductive health program, and there's the linkages all the way through. I wonder if you could say something about, from your experience in the countries you work in, how does it link up with work that's being done on WASH? And are the WASH people a bit more ahead of the game thinking about gender equity?
That is a very important question, and it addresses actually two things. One, it addresses the fact that the major determinants in low and middle income, as the social determinants of health, and we're looking at things that are like access to clean water, and safe water. We're talking about the issues of sanitation. We're talking, because 1 in 3 hospitals today, in the African region has no running water. I work in these hospitals from country to country. We don't see that, what we see in the health sector, in the clinical setting, is an extension of what is happening in communities, because in communities, they don't have that. We have had the WASH programs for a very long time, but still today, there is lack of water. You see that the same water that, we are washing our clothes in, it's already contaminated, and so and this is where I think it's really important for us to broaden these conversations and, have broader conversations with our WASH folks at country level, who should be sitting in when we have these meetings at, national or state levels. But what we see is that even when we look at the team that is really composes, these sort of working groups at country level, sometimes the WASH guys are left out, and yet they've been doing this for a very long time. And I think it's important to connect issues of WASH and have, we have a critical mass of us and really intervening at various stages and not just having one solution at all. Thank you.
Okay, great. Who would be on your dream team then, Murphin? So if we've got a WASH person, and maybe we've got Juliet as our anthropologist, who else are we going to have on this dream team that work together to think about how we tackle gender equity in AMR?
Yeah, I think, so I think one of the things that we need to do is we need to actually include our community members. And this is very critical that, the change that's going to happen will only happen if, we have empowered communities. And how do you empower those communities? It's by providing, knowledge and evidence and understanding certain nuances, cultural, socioeconomic nuances that are very, very important. I think when we chatted with you, I told you that I was in one of the countries, and it was really, really eye-opening for me. I'm in this country. I've gone in to actually support the national team with really setting up antimicrobial stewardship groups in the hospital, and also helping them to develop a national policy for stewardship. And so, naturally get one of the team members I found, they were getting really support from the WHO country office. And this doctor tells me that, we are conversing on these issues, why stewardship and all that. And, she gives me an example, say, do you know that, even in this office, if I said, asked my fellow women to open up their purses or their handbags, one of the things that you're going to see common, and over 98%, they'll have antibiotics in their bags. And they'll also have antibiotics, and in the community, it's actually the same. And I asked, what do you really mean they, so no, there is a belief that, when you go through menstruation, you have to take antibiotics. So it's this social, the cultural side that, we need to think about. The drivers of these behaviors, the inherent beliefs that people have from, what they have been taught. And so, so the community should not just be, they should come to this conversation, sitting down, involving them because then we learn more of what is happening, and we are able to find really common solutions. And also, once we have this sort of input, our sort of interventions are going to be grounded in what happens in practice. This may not be a practice in other countries, but this was, one of those things that you get to know and learn about when you're interacting with community members. And so, it's very, very critical. Of course, we need the support from the top that actually looks at, how do we really look at AMR and take advantage of some of the running programs like WASH, and including elements of really these disparities that we have, including our education sector, et cetera, et cetera. Thank you.
Thank you, Murphin. So there's a nice little segue there to Sarah Powlin, WHO. We're just past the halfway point here, and I just want to remind our listeners, our people, it's been great seeing things happening in the chat. Don't forget, if you've got a question that you want, or something you want the panel to, the guest to react to, please put it in the Q&A, and then we can raise it towards the end. But let's keep going, and we're going to move over to Sarah Powlin. So Sarah Powlin is a technical officer on AMR at the Department of AMR Surveillance, Prevention and Control at WHO headquarters, where she leads the development of norms and standards, as well as technical assistance to countries for the sustainable implementation of national action plans on AMR. She co-leads the development of the recently launched WHO people-centered approach to addressing AMR, and is currently overseeing the development of some policy briefs, which you're going to tell us about, aren't you? So, Sarah Powlin, what are you making of it so far? Are you liking what you're hearing?
Thank you, Cheryl. First of all, thank you so much for having me and everyone on this panel, and everything that has been said so far. It's incredible how passionate everybody is about this topic, and I couldn't agree more with everything that has been said before. And I just wanted to touch on a few points, and maybe that will also then lead into why WHO is doing what it's doing, and also our future plans. And so the first point, I think it was both Giada and Dame Sally Davis mentioned it, is that really bringing the people and the human face to the action of AMR. When we talk about antimicrobial resistance, I mean, the title of the webinar says it all, moving beyond drugs and bugs. And that's something that WHO really is also passionate about, and why we developed the people-centered approach and the 13 core intervention package, because that really looks at AMR, sort of what we call across an AMR people journey. And then I'll get to why gender is such an important part as well. But just briefly, if I can touch upon that, it's thinking about the people. And of course, here talking also about gender diverse populations, talking about all populations before they become a patient. And often that also already is having asymptomatic infections as well, of course. But let's say before they're seeking health services, there are people and system challenges that are faced based on context. And here also different gender groups have different challenges in different contexts, but some of those are behavioral and people challenges, and some of those are system challenges. We've been talking about WASH and infrastructure, for example, also stigmatization, etc. And so these are really systems issues, much broader than that go beyond even the AMR area. And so the people journey really looks at sort of prevention first, and here thinking about IPC, WASH, and immunization being the critical elements for what we say pillar one of the people-centered approach. Then moving into accessing health services that are of quality, primarily here thinking also about primary healthcare. And I think it was Murphin already mentioned, this is where the majority of, in particular, vulnerable groups are trying to seek healthcare, often drugstores, informal markets. And so this is also thinking about the quality of health services and the products that different groups receive. And we know, and a lot has been said already, is there are gender inequities in that. And then moving on to diagnosis. And so even when either the provider or patient is looking for a diagnosis, and this is where actually the evidence on gender we saw was the least, is that there are also inequities when it comes to diagnosis. Men who have sex with men, for example, don't have trust in the healthcare system often, in their GPs. A lot of that comes down to stigma. There's also underdiagnosis, certain groups not seeking diagnosis, loss to follow-up, and then finally to treatment. When looking for appropriate treatment, the final pillar of the people-centered approach. Again, here there are people and system challenges that also have very large gender inequities depending on the context. And some of that are also power dynamics between the healthcare professional and often women. And then that has implications on the actual completion of prescriptions for both women, but also for their children. And so by looking at it through a people-centered approach, we really were trying to think about, let's make sure that nobody is left behind in the AMR response at country level. And of course, this has then also the different groups and where we're now conducting policy briefs to really think about what is the evidence and then translating that evidence into policy considerations. The first being of the topic today, gender and AMR, and the other two are equity in AMR, and finally social inclusion in AMR. Disability inclusion and AMR, and that has already been mentioned as well. And so yes, we had the delight of having almost everyone on this call with us in Geneva last week, and we went through the evidence, be it limited evidence, but this is building off, as Bertie mentioned, the work we did in 2018, and then the additional primary, but also systematic reviews that have been done, also really grounding on the work being talked about today, and looking at the evidence, also thinking about expert opinion because we know the evidence is limited, and then thinking about what are some practical policy recommendations, primarily to policymakers when designing, implementing, and monitoring their national action plans. And I mean, if I could just describe three, I would say, low-hanging fruit that came out. The first would be when looking, and I think Murphin already alluded to this, when looking at the national AMR committees, actually ensuring that they are gender balanced, that they link with the ministry in the country that is responsible for gender equity, or even within the Ministry of Health, when there is a gender expert, ensuring that they are brought into the National AMR Committee, because at the end of the day, they are the ones who are designing the national action plans. They're the ones, if there will be budget coming, they're the ones deciding where the money will go, especially if it's a domestic budget line. So they need to be involved in co-creating the interventions. Secondly, it's already been mentioned, a lot of countries are sitting on a lot of data, and we need to disaggregate that data by sex or gender to really analyze and then let that inform the actions we need to take to start addressing the gender inequities. And then lastly, is really when thinking about the next iteration of national action plans to undertake a barrier assessment, thinking about the people-centered approach, the different pillars from prevention to treatment, and then bringing in the gender lens, because the barriers that different gender groups in different contexts and countries face will be different. And so we really need to do this at each country level to understand what are the gender inequities, who are the main gender groups that are most vulnerable in that context, and then tweaking the interventions to make sure they're not left behind. So I think I'll stop here for now. Thank you.
Okay, great. I'm glad you brought up the low-hanging fruit, because that was something I found really useful talking about, because we're moving now into the, okay, I get it, but what are we going to do about it stage of our conversation? But this low-hanging fruit that you were talking about, is it something that people like yourself are seeing because you're a step removed? Or is it actually kind of still actually slightly out of reach? Why hasn't it been picked yet? If it is low-hanging fruit, what's kind of standing in the way, and what needs to happen for that to happen?
I mean, I can start, and I'm sure the others have a lot of experience on this as well. But I think it goes back to the point that Murphy made. People are not aware. We need to sensitize everybody, no matter what part you play as an individual, as a policymaker, as a healthcare professional, Murphy's point, as colleagues, as veterinarians, etc. They need to understand the why. I think we haven't really been able to sensitize everyone, and only once they have the why can we move to the how. And I was talking about low-hanging fruit in terms of how, but until we acknowledge the aha moment of the why, I think that's, to be honest, I think the main hurdle, and why this webinar or this chat show today is so important, but we need to continue, and this really needs to trickle down to the community level, because as I fully agree, they are one of the major players that haven't been as involved as they should be, and in particular, in my opinion, women voices. Thank you.
Okay, great. So I'm going to open a question to everybody. I will be coming to Erica on her own in a moment, but this aha moment. So Murphin talked about a medical professional coming up to him and saying, I've been doing this for 30 years and I've only just realized this. How do you make people get to that point? What examples, have any of you had examples, it can be used by Erica, where you've kind of brought people to that awareness? What works in raising awareness? Give me a wave if you want to answer. There he is. Go on, Murphin. If you're on mute, let us know.
Yeah. I think it's it's something that is probably not very complicated. I think we've been learning that our initial ways of doing things, we took it for granted, as actually scientists and clinicians, and when we are looking at a patient, we just look, we're trying to fix a problem, and that's where our focus primarily ends and what. And so there isn't we're coming from a background where we were not looking at factors beyond just say health, beyond the veterinary sector, but what is it that makes people make these decisions? And I think when we have really challenges around how do we make AMR, which is a phenomenon, easy to understand, because we still are struggling to communicate with the larger community we should be focusing on. And I think that's why I think I was saying, we really have to find a way to break these things down, start raising awareness, having some campaigns, ensuring that at national and country level we are supporting in any way that we can. In a few countries we do have a situation where there is the Ministry of Gender and it focuses on women. Sarah spoke about vaccinations and immunizations. Who take the children for that? Again, it is females. It is women who do that. Men don't do that. And so, we have to target on these issues. We have to target both, male and female to be involved in these conversations. And I believe that, with health literacy going up, people start making better decisions. People start asking their governors, their members of parliaments, they start asking for what now they have learned should be, the standards of care, the standards that every citizen should enjoy. But currently there is a disconnect, that the larger portion of the community literacy levels are very low, and they don't think that they have a role to play. One of the things that I've been also focusing on has been to challenge professional bodies to be able to be the voice for their practice, the voice for the patients, the voice that addresses and brings these issues to the members of parliament, the policymakers, because they have to hear from them. They should speak on addressing these issues. And so, really the key point is just that, we have to focus on, improving the literacy levels, people who are empowered and who know they start making the right decision, and they start having the asks and holding accountable our leaders that make the decisions that contribute to these inequalities and gender blindness.
Oh, Juliet, do you want to come in?
Yeah, to follow up on what Murphin is saying, it's a very interesting approach, and it's completely it's necessary to have these kind of from the local ground up to kind of be able to speak directly and for this advocacy. And I'll just bring in the kind of another part of this, which we open our paper with, and we say, and on a global scale, a lot of the time mortality and economic burden also speaks volume, and particularly when it comes to policymaking advocacy, sometimes these numbers speak volume and then are supplemented by this community approach, and with having the local community be able to speak. And we open this our paper by saying, in 2019, 4.95 million deaths were associated with bacterial AMR, with the highest death rates of which is in Western and Sub-Saharan Africa. And it's estimated that unless action is taken, this burden of death from AMR could balloon to 10 million lives each year by 2050. And based on these scenarios of rising drug resistance, it's also estimated by that 2050, the burden of death from AMR would rise to a cumulative cost to global economic output of $100 trillion each year. And this kind of increase in expenditure and mortality, decrease in health and fitness, really kind of will become reflected in a multi-country, multi-sector kind of reduction in labor productivity, increasing healthcare costs, disability, and other effects on poverty. And while this an economic approach can be informative and is quite interesting and useful in policymaking advocacy, that's where Murphin's contribution really comes in. Really interestingly, because it does lack the ability to put a human face to the problem, as we mentioned earlier. And these kind of long and chronic disease progressions that are associated with antibiotic-resistant pathogens really have this severe impact on an individual's quality of life, physical fitness, mortality. And we really require this human-faced approach, which is what we're trying to push here on an individual level, with both the social economic impact of people with antibiotic-resistant strains, which kind of has a dire impact on their ability to work and partake in daily activities. Also, the very fast emergence of highly resistant pathogens occurs amongst older patients specifically, and so with this, life expectancy is also kind of forecasted to shorten unless there's preventive strategies that are coupled with kind of new drug developments to be established. And so the question is also, why does this intersectional lens therefore matter in this research if we're only talking about, either if we're only talking about economic or death and mortality, but incorporating this intersectional lens into this health research and the social epidemiology is really crucial to actually identify and characterize the most at-risk groups to AMR, and therefore ensure that the interventions, the actual interventions that people are implementing on the ground, target those who are most in need of those. And we won't fix this without this lens. This is where this kind of equity and global justice aspect comes in, where our paper outlines that there is kind of this disproportionate burden of AMR in different regions of the world.
Great, thanks very much, Juliet. I'm going to bring in Erica now. Hi, Erica's been sitting patiently listening to everything, saying, God, I hope they don't say everything I was going to say. So Erica is a public health researcher and program manager. She's got loads of different experiences in infectious disease programs in low middle income country settings. She's also got a lot of work that she's done on social determinants of health with vulnerable and indigenous populations. So you're currently the senior science advisor. Do you call it ICARS, ICARS?
ICARS, yes.
ICARS. Okay, and you are leading the development of a gender equity and AMR program. So I can see why we brought you along. So what have you heard so far that you want to comment on and can kind of bring in from your work?
Well, A lot. I think there's been such excellent contributions from all of the panelists, and so much has been said. And I'm actually very thankful to almost have come at the end, so I don't have to reiterate so many aspects of the complexities of antimicrobial resistance and gender and intersectionality. So I won't add on to that at this time. But what I wanted to talk a little bit about is what we're doing at ICARS and how this might help some teams start to actually address this gap. So for those that aren't aware with how we work at ICARS, we look at implementation research and specifically working with ministries and research institutions in low and middle income countries to help them to develop interventions using an implementation research lens to be able to address the AMR challenges that they've identified. And what that means is that when we're implementing these programs, we need to understand what works in what context. So when I joined ICARS, 3 years ago, it became very clear that to implement many of these solutions effectively, we really needed to understand some of the contextual challenges. And with that, gender was just such a common strand. And then that led us to explore equity even further. So we started a bit of an initiative on this since 2021. And I have to say, we've been very lucky to also work with the International Development Research Center in Canada, who have been such a leader in the area of gender. We're working with them largely in an animal health sphere. But really, we wanted to start to understand what does the research community need? So Sarah talked a lot about the policy and what WHO is doing to advise policymakers on what they can do in developing national action plans. And so at ICARS, we want to come in from more of the research level and understand what can researchers start to do, knowing that as many of the panelists have mentioned, traditionally AMR has taken a very biomedical approach in terms of understanding how solutions are implemented. And so we want to sort of take a step away from that and help researchers that are working in a biomedical lens. So it might be researchers working on a veterinary project. It may be a hospital stewardship. It could be something based in the community as well. But we really wanted to understand what can they start to do so that research is no longer gender blind, so that we start to have gender sensitive, gender responsive, and ideally transformative solutions that can actually look at how we empower vulnerable communities while ensuring that they're not having a disproportionate burden of AMR. So that's where my interest really sits. And at ICARS, we try to be very solution oriented and try to implement something that is very feasible. So what we've actually been working on for the past year is to understand what are some practical steps that researchers can actually take throughout the research cycle. So starting at the inception of a problem, moving into the proposal, all the way through data collection, analysis, and reporting, to be able to understand what are some very practical things that researchers can actually start to do to start to integrate a gender and equity lens. And that's really been the area that we've worked on. So we've worked with great research communities at Mahidol University in Thailand, as well as the Human Sciences Research Center in our council in South Africa, as well as another company to actually develop a resource document that can help teams to start to implement a gender and equity lens. But I think one of the things I wanted to emphasize is that, as has been so clear from what all of the panelists have brought forward, is that the interactions between gender and intersectionality and all of the different intersectional interactions are complex. So this is also an area that we want to see more social science researchers working alongside those already working in more of a biomedical landscape to really bring multidisciplinary solutions. I think it was Murphin that talked about the need that we need to have more contextualized solutions, that solutions need to be grounded in what happens in actual practice in communities. And that means that we really need to be able to understand what is happening. So building on also what Juliette was saying in terms of also needing a broader contextual approach that looks at the specific interactions in different areas, that complements the excellent review that we're talking about today as well, that shows what a range of impacts there actually are within AMR when you start to look at it in terms of interactions with vulnerable communities and the different intersectional interactions. So we really want to sort of be able to provide some solutions that can also help researchers and others working in implementation research to start to implement some techniques so that we start to see that we now see that gender and intersectionality become much more common in AMR research. And I think that's you mentioned the aha moment. And I think that's what we want to try and start to move towards. So one of the things that has been quite interesting is that I've had the chance to talk with a lot of our research communities about what equity and gender mean to them. And for some research teams, it's so inherent in what they're doing, but it hasn't been described as such. So one of the areas that really drew attention to the need for this lens for me and for ICARS generally is we work a lot with, we have quite a few projects looking at the poultry sector, particularly in sub-Saharan Africa. And a lot of those are small scale poultry farming settings. And we see that in most of those contexts, they are women-owned businesses, but it doesn't mean that that extension services and other animal health services are always directed towards women or are making a potentially different approach to engage women. So it may be that many of these services are actually more often provided in male settings. And so we may be missing we know we are missing many of the needed communities when we're implementing these different interventions, but it also means that we could be unintentionally exacerbating existing vulnerabilities. So that's where we're hoping to go at ICARS and hopefully be able to support other teams as well in bringing a gender lens and an equity lens into the work that they're doing.
Brilliant, thank you. And when we were chatting, you gave me a couple of interesting resources. There was a One Health Trust podcast that you're going to send me the link of, I think, and also I've asked all of the guests today. They're sending me various links of papers they've talked about, or they might be having some coming out soon. What I'm going to do is I'm going to put those links in an email to you all afterwards, with a link to this recording, and also invite you, if you want to be told about stuff that's coming out from these organizations, to let us know so that we can make those available to you, because there's more coming, isn't there, Sarah? In next quarter we've got more to come. So let me just pick up and just say, for the people listening, if you've all got a lot of experience, that's why you're here. You're not here because you're completely blank to this issue. So what do you think should be shared more widely with people? So if there's a website or a publication you'd like to kind of share around, please put it in the chat so that everyone gets to see that. I'm just going to pick up some of the questions now that we had submitted, not necessarily by people who were able to come in the end. So we've already, I think, talked about how we can translate research findings into practical applications. One of the questions we've had, Murphy, and this might be one for you, is how can we use what we're learning to ensure that different sexes and genders have access to the right treatments at the right time? Doesn't sound like a small question. What's your short answer?
Yeah, my short answer is this is like the issue we had for a very long time, where we looked at babies and children like they were small adults. And so even when we were doing like the forecasting, whether it was at the hospital level, it was at the national level, was that, we never really considered that. And even the sort of formulations that we had were formulations that were not really child friendly. They were bitter. They were, babies and children could not take them. When we started realizing, we started, for example, that was when disposable amoxicillin was actually developed, because it would it would actually dissolve almost immediately. And so we became sensitive to that, and we realized, and as a global community, we started moving towards ensuring that was happening. Sarah had made an excellent point when she talked about that, there is data. How do we disaggregate that data to start helping us with the decisions we are making? What is our, how do we ensure access? How do we ensure that, if we have certain patterns of certain molecules that are being used by one gender unlike the other, how do we ensure that even through our forecasting, our purchasing, we are taking into consideration these distinctions? One of the factors that, has been mentioned here, has to do with, the differences really physiologically and the anatomy that we have, and the differences in terms of risks. So it's important that we once we have more people integrating these, not just at a policy level, but this sort of we need to be revising and getting other sectors involved, like educational sectors, that are training our nurses, that are training our doctors, our pharmacists, our lab assistants, and whatever they are training. They start getting involved. And one of the ways that we've done it as REACT is that we've got a flagship program that focuses on tertiary students in the African region. Over 30 countries are now involved, where we meet every Saturday at 8 a.m. for 5 to 6 months, run them through all these issues and sectors, and SDGs, and the environment, what is WHO's role in and we do all those, and they get exposed. And these are students coming in from very different disciplines. There will be engineers, some are going to be teachers. With the women groups in churches, we've been working with women groups in churches now to, as an entry point, to raise again that awareness and build the literacy levels. But from the clinical side, is that, we have to ensure that we have the right tools to help us with a diagnosis. We utilize the local data to understand these differences, ensure that we have actually equitable access. We don't have the chronic stockouts we are currently having in African countries, because our dependency on importation of all medicines is over 90%. And so it's very, very high that we have to import. And with the challenges in supply chain, it becomes an issue. We need to go back and address this issue, where we are now seeing a decline in vaccines, vaccine uptake in children, because, since COVID, the disinformation, the misinformation, and, it completely has added into all this. And so I think it's important that we ensure that we have the tools to know what we are treating, and that we have the molecules in the right amount, and the molecules that are acceptable to and are easier to take, and formulations we can combine that. We don't have 20, 30 tablets that somebody has to take, but they can only take maybe 1 or 2. Yes, so I think that's just one area that we can look at. Using that data would be important. Thank you. Mm-hmm.
Okay, I'm going to come to you, Sarah, just in a sec. When I've heard from Sarah, I'm going to go around everybody in the last few minutes, and what I want is the one thing that you think people should do in the short term. What should they do next? The one thing in maybe the next month or 2 or 3, might be even this week. What should they do to take this forward? Okay, so that's what I'm going to come to you in a moment. So Sarah.
Yeah, thank you. Sorry, just wanted to jump on what Mervyn was saying as well. I mean, I would say that, and this came up a lot in our discussions last week, was empowering community health workers. We know in particular for a lot of the gender inequities, in particular for women in low and middle income countries, it's going to be the community health workers that they're going to seek first. So they need to be aware and sensitized about the sex and gender dimensions around the prevention, diagnosis and treatment of drug-resistant infections. I couldn't agree more with Mervyn in terms of thinking about diagnostics, and this came up as well, as we really need more innovation to bring the diagnostics to the women in the community, in particular for detecting drug-resistant UTIs, for example. And then finally, because we know that cost is one of the major barriers why women, but also men, and I would say all gender diverse populations, aren't able to access, for example, a healthcare professional, and then often go to the drugstore and perhaps not fill the full prescription, is because it's not covered under health benefit packages. And so I think that is also an important area that countries need to review what is in the health benefit packages. Does it address the key syndromes that are impacting women, men, and gender diverse populations? And then just a final point on innovation, because Mervyn also mentioned that, is when thinking about clinical trials, and this also came up in our meeting, is really ensure, and there needs to be transparency around this, ensure that there is gender diversity in clinical trials, but also in particular representation from underrepresented individuals, such as lactating and pregnant women. And I couldn't agree more. We need still a lot more pediatric formulations for a lot of the existing medicines if we really, really want to get over the access barrier. Thank you.
Great, thanks, Sarah. Now, before you go, so you can give me either one key message you want people to take away or one thing you want them to do. What are you going to give us?
All right, I'm going to just let everybody know that we'll be publishing our policy brief probably in March or April next year. I would like everyone here, please, when that time comes, is join what we will call our community of practice. So we have an online community of practice, but we will start a discussion group in particular on gender and equity. And I would really invite all of those to join and to share your experiences at the country level, because we know that all of the different barriers that you face are so context specific. And so I invite you to join, and then also make sure you share in that group. Thank you.
Great, thank you very much, Sarah. I'm going to go to Jada and then Juliet. Jada, one takeaway or one action?
Thank you, Chagol and everyone. Yeah, like, I mean, if we're talking really like short term and something we could all do, I would say, linked to what I think Mervyn said at the beginning, like just spread the word, raise awareness, keep ringing the bell or whatever, like just using like our paper and other resources that have been shared in the chat and or that we can share with each other. Really, like in the work we do, keep applying a gender lens and asking yourself and others the question, why it matters and what we can do about it.
Great, thanks, Jada. Juliet, would you add anything?
I think the first thing is read our paper if you haven't read it already.
Yes.
Read the future papers that will be coming out on this topic. I think my key message would be that we really need additional research, data, and evidence to be able to push this forward, especially when it comes to policy making. It needs to be really informed by a lot of evidence, and that's where sometimes there's a bit of a roadblock. So I think we really need to work towards funding for additional primary research, whether that's in terms of collecting the microbiology data that's disaggregated, or anthropological research, or community-led, community-based research. So that's my key message, is we really need to put
That little alarm was me saying it's time to stop. So I'm going to go to Mervyn for one last thing from you, and then I'm going to come to Erica, and I'm hoping you're going to plug what's in the chat.
Yeah, I mean, it's thank you so much actually for the opportunity, and I'll just amplify. I think one point is that we what we have discussed today and the resources that are being shared in the chat. My parting words are, it's time to act. It's time to really look at, the impact, the differences, the existential threats to achieving sustainable development development goal number 5 on gender equality. And actually AMR, if we don't take the gender lens and we don't have our communities get to a level where they understand, it'll just be revolving door. We may not be able to go further. So it's time to act and to use the gender lens in our interventions and everything that we do. Thank you.
Thank you, Muffin. And finally, you, Erica?
Well, I think that's the perfect thing for me to follow, which is to say that we need to start then implementing strategies in our interventions, in our research programs that can actually create the evidence that Juliet mentioned and do exactly as Mervyn has said. So I would encourage everyone to look across the work you're doing, look for opportunities for bringing in intersectionality within your work. We live in a gendered world, so the research should also bring this lens in. And with that, I would actually say that we are going to have a webinar on the resource we've developed this week, talking through some of the actual practical strategies, things around sample size, data collection, how you're doing monitoring and evaluation, how to get community input, who are your data collectors. So I will just, and I think there's a link in the chat already from my colleague on that, but please join us if you'd like to learn a little bit more about how you can start doing this very quickly. Thanks.
Great. Thank you. So just a final thank you to my guests, to Jada, Juliet, Sarah, Mervyn and Erica, and also to Dame Sally. And also thank you very much to the other authors on the study, and also to my colleagues Sarah and Giovanna, who helped pull this all together, and others on the Itad team. Thank you very much. This has been fantastic, really interesting, and is the step on a longer journey, I'm sure, of interesting conversations.